So I think the reason that we are discussing this topic is cough, when to treat and when to wait. Because cough is one of the most important primary protective reflex will all of us are lucky to have. So there are some pathologies where we can afford to wait for cough, and there are some pathologies which actually tell us what are the underlying etiologies of cough. So today's agenda, we will be just having a general introduction about cough, the cough physiology in short, what are the common etiology and the cough duration that will help us know what could be the underlying cause, and classification of cough, whether it is a wet cough or dry cough, and management when to start. Regarding the cough syrups and cough management in detail, we will have a detailed panel discussion with our esteemed faculty. So first and foremost, when we talk about cough, it is one of the most common symptoms which each pediatrician would be dealing at a large extent. And it's a primary symptom most of the times we see in our OPD. So what happens if the cough happens? It basically will limit a child's ability to play, to sleep, school. Any kind of nocturnal cough is pretty disturbing to the child. It will not only limit the child's ability to play, but also to eat or to have a normal daily routine. So children in cough very different from adults because the etiology is different, how they perceive cough is again different, the etiology is different, and then again the management will vary. So cough physiology, like I have already mentioned, it's a defensive mechanism which protects our airway. What happens when your cough is ineffective? It will obviously lead to aspiration and recurrent airway infection because we are not able to cough out the underlying inflammation or if infection, bacteria or virus or the excessive mucus which is getting produced. Now, how do we describe the physiology of cough? You know, it starts with a deep inspiratory effort, followed by a forced expiratory, and it happens against a closed glottis, and this will result in a rapid expulsion of air. Now, if you see here, you see we have cough receptors literally from your larynx to your segmental bronchus. Now, there are various stimulus. Now, this stimulus can be in the form of chemical irritation or mechanical stimulation or even tactile stimulation. Now, we have the vagus nerve and the laryngeal nerves, which are related to the brain stem, where the impulses are modulated at the cerebral cortex. From here, the afferent motor nerves or pathways will go to the respiratory muscles and which will aid in our cough expulsion, like the one which I have already mentioned as the cough physiology. Okay. Now, as far as the etiology, we cannot have the same etiology in a child who's less than 1 year and a child who's more than 1 year or older children. Now, in children who are less than 1 year, the commonest etiology is viral. It could be a viral bronchiolitis or viral laryngitis or tracheitis, anything which is preceded by viral infection. Bacteria, as you know, pertussis, pneumonia, chlamydia, mycoplasma, these are the common infections that you would now see in children who are less than 1 year as well. We also see congenital anomalies like tracheoesophageal fistula, cystic fibrosis, PCD, vascular rings, or pulmonary sequestration, or any underlying airway malformations like airway cleft or laryngeal clefts. Now, as I have already mentioned, now in children who are a little older, that is in preschool and older age group, what do you commonly see? Foreign body aspiration, well, a little in the younger age group between 1 to 3, and these kids may not always prepare and come with, sudden episode of coughing or choking, because it again depends on where the foreign body has been lodged. Asthma and allergy is again one of the most common cause of cough in children who are less than 5 and even more than 5 years of age. Pneumonia, again, it can be either viral or bacterial. Bronchiectasis, like prolonged wet cough, we really need to think of underlying etiology like chronic suppurative lung disease causing bronchiectasis, right middle lobe syndrome, passive smoking inhalation, which is again one of the causes that we have been seeing very of late. We have been seeing it more commonly. Gastroesophageal reflux, as I had mentioned in children less than 5 years, can also be a complaint in a little older age group with congenital infections or children who have obstructive sleep apnea, where they come with recurrent gastroesophageal reflux and then other chronic lung infections. Now, cough, as we know, can be classified whether it is a wet cough or dry cough, as well as acute or chronic. If it's a cough which persists for more than 4 weeks, we can mention that as an acute cough, and anything more than 4 weeks can be called as chronic cough. Now, why this deadline of 4 weeks? Because we've seen there are a lot of post-viral cough which can persist in children for 4 weeks, and that is why we don't really need to subject them to giving unnecessary antibiotics. So on basis on clinical examination, you can take a call whether you think the child is otherwise normal, playful, and it's only coughing. It can be an irritated or an underlying inflammation secondary to post-viral cough. Now, again, the etiology, like I say, the other thing other than acute and chronic, we need to know whether it is wet or dry. Sometimes this demarcation may not be very, very obvious, especially in small children, because it may be that, the child coughs and can swallow the phlegm. In those cases, it is very difficult for the parents to exactly distinguish whether it is wet or dry. But acute cough, as we see, can also be wet and dry. So what are the commonest causes that we see in acute wet cough? Usually it is acute infections like viral, bacterial, tracheitis, or laryngitis. Any of these can come as acute wet cough. Whereas acute dry cough, the common one we see is asthma, tracheomalacia, bronchomalacia, or any vascular rings that I've already mentioned as underlying congenital malformation. Chronic wet cough will usually lead us either there is an underlying infection or an underlying long-term inflammation, which in our setup is usually due to any congenital infections like cystic fibrosis or PCD or any interstitial lung disease. Chronic dry cough, as we have seen, the commonest one we see is asthma, or I have mentioned post-viral cough, pertussis, or any tracheal tumor. And last but not the least is a psychosomatic cough. Now, wet and dry cough, like I said, that it is sometimes very difficult for parents to distinguish whether it is actually wet or dry. Maybe a little older child, we could be able to differentiate better. A wet cough would usually indicate that there is excessive mucus secretion or impaired mucociliary clearance, as we see in children with cystic fibrosis or PCD. So dry cough is something where we can give an idea that probably the airways are, subject to airway irritation or inflammation, or it can be a non-airway cause. Okay. Now, how do we go about seeing, whenever you have a child with cough, what are the things that you're going to do? The first and most important, a detailed history is very, very important. Like I said, sometimes choking episode may not be a history that you can come across, but chronic prolonged wet cough is something which could really trigger you. That could it be a foreign body which has been long standing in the child. Swallowing difficulties may not always be present, especially in child with gastroesophageal reflux. Shortness of breath, whether chronic, exertional, exercise induced. So you can ask children, how do they feel when they run? Are they running a little less than what they used to run? Do they need to take short stopovers before they start playing? So this would be a pointer towards, are we dealing with asthma or a chronic wheezing child? Failure to thrive and hypoxia. So, taking a pulse oximeter or saturation is something which we should do mandatory, because chronic interstitial lung disease can give us a pointer towards, these kind of hypoxic damage to the airways, to the interstitial. Hemoptysis and noisy breathing, like I said, hemoptysis again would be either if there is any underlying chronic lung infections or inflammation. Now, again, we have a variety of causes which can cause hemoptysis. First and foremost, it is important whether to confirm if it is actually hemoptysis, the duration of hemoptysis. Is it frank blood or is it associated with sputum? What is the color of the sputum? So these are things which you need to investigate when you take a detailed history. Now, in children who are a little older age group, as we see in children who are more than 13, sometimes these kids can be having, they also come with malingering, and they can have tongue bite or teeth bite where they can come with just bleeding from the sputum. So you have to be very mindful of the age and the detailed history when it comes to hemoptysis. Noisy breathing, like I said, it's usually seen in a little younger age group. depending whether you're dealing with laryngomalacia or bronchomalacia or laryngitis, tracheitis, depending how the child is the child comfortable, is the child very toxic, is the child febrile, is the child cranky. So all these things help us in filtering and knowing what the diagnosis could be. When you do the general examination, first and foremost, it is important that you lie the child down and see for the activity of the chest. So that includes whether the child has got respiratory distress, subcostal, intercostal retraction. That again gives us an idea where exactly could be the likely cause of obstruction. Abnormal lung auscultation, whether the child has any adventitious sounds in the form of crackles or wheeze. Along with that, the overall general examination of the child would involve if the child has got any associated craniofacial abnormalities or chest wall abnormalities or any neuromuscular disorder. Now, in neuromuscular disorder, as we see, in children who have neuromuscular disorder which are prolonged, they have an inefficient cough system and they are not able to cough out. So these children can come with recurrent chest infections and failure to thrive. So when we start about one, we have taken the detailed history and examination, we go on to management of cough. Now, do we, investigate each and every cough that comes in your outpatient department? Well, obviously no, because you've already gone through the history, the clinical examination, how is the child presented to you, what are the prodromal symptoms. So all of this will go entirely in managing the child of cough. So first and foremost, as we have discussed, we are going to take a detailed history and detailed examination of the child. We are going to ask for the duration, if the quality of the cough, whether it is wet or dry cough. Are there any particular triggers? Like, if you have a child who is asthmatic, so do they have any pollen allergy, any fungal allergy, dust mite allergies? So these are the triggers that we commonly see. Do you have any diurnal seasonal variation of the cough? Are there any associated symptoms, like if the child, has vomiting post feeding with liquids, or does the child have any craniofacial abnormalities? So these things also can be helpful. Neonatal history and family history will help us to know if there are any underlying congenital lung infections or congenital lung malformations. Environmental exposure, second-hand smoking, there is something called as third-hand smoking as well. Now, that is when there is, smoking particles or nicotine which can stay on your furnitures and sofa, which the child can inhale. So that is a third-hand smoking. Medication and allergy history will be a pointer to know what the child has been previously taking and what has gotten him better or is in something which is worse in him. So these preliminary history, you can definitely have a look. Now, when you're doing the medical examination, you have to check if the child is febrile, irritable, is there any failure to thrive? Because these are pointers which help us to know whether the condition is acute, chronic, or which has been going for a long term. Nutritional status and physical signs, especially when you're dealing with failure to thrive in chronic suppurative lung disease, interstitial lung disease, or some underlying, long-term inflammatory conditions. Noisy breathing, clubbing, cyanosis, similarly for any chronic underlying lung infections. Respiratory distress and tachypnea will mostly is something which will again help us to know whether it is an acute or a chronic condition, how well the child has adapted to the respiratory distress, and air entry to know whether it is decreased or normal, especially when you think, you could be dealing with either a foreign body, whether it's a polyphonic wheeze or, also a multiphonic wheeze. So, and plus if the air entry is decreased on one side. So this will help us to know the underlying cause and the adventitious sounds, if any. Now, any child who comes to you with cough, do we really need to investigate? Do we need to do a battery of tests for these children? Well, the answer is no, right? So if you have a child who comes to you in acute presentation, and most of the times in children's or toddlers, you see that it is an underlying viral infection. You see the child is coughing, but the child is playful. There is no fever, but the child is having this dry hacking cough, but the child is otherwise active. You're dealing with something like a post-viral cough. then it's better to leave it to heal by its own. It's better to just wait and watch. But chest radiograph, you need to do it. Maybe you need to take a filter and see. If you feel that there is a chance that the child could be having a lower respiratory tract infection, depending on the findings that you have found on respiratory infections, you can take that call. You want to know what is the nature of the cough. Has it progressed? Has it worsened? Has it become diurnal? Has it become nocturnal? Is it disturbing the child? Is it really, faltering the child's growth? So these cases, you can think of doing a chest radiograph. Or if there is an undiagnosed chronic respiratory disorder. Bronchoscopy, it's the next level of investigations, which probably is not done at every setup and every center. But if you think that, you could be dealing with foreign body, if suspected foreign body, or if there is an excessive mucus plug which you are suspecting, which could be obstructing the airways, then in that case, you need to have a bronchoscopy for foreign body removal. Or if you think that it's a chronic lung disease, especially in children with cystic fibrosis, PCD, or interstitial lung disease, where you want to know the underlying bug, you can do a bronchoalveolar lavage. Allergy testing, if a child is an asthmatic child, or if they have symptoms pertaining to allergies, then allergic skin prick test is the gold standard test. Well, lung function test, like I said, if it's an older child, any child who is beyond 6 to 7 years of age, you can have spirometry, or you have the FeNO test. But these are again limited, these are present at limited centers, and these tests the child may not be able to perform. So again, like we said, asthma is basically a clinical diagnosis. But if you have the facility of doing lung function, you should definitely go ahead and do it. If you suspect symptoms suggestive of gastroesophageal reflux disease, then pH manometry is an associated investigations which you can team up with your gastro team and then go ahead and do it. Now, children suggestive of habit and psychogenic cough can benefit from psychotherapy, such as suggestion or behavioral therapy. Now, mind you, psychosomatic cough is a diagnosis by exclusion. If you think that the child has come with symptoms which does not particularly fit into any etiology or any variation, and the child can voluntarily stop his cough whenever he wants to, the child gets deviated from his routine activity, or his attention is deviated and the cough stops on its own, and if you have ruled out most of the underlying causes, only then we can think of a psychosomatic cough. Now, when we go about in management, there are certain general concepts that we need to deal with. One, like I said, we need to identify, most importantly, what is the cause of cough in children. Secondly, if it's an upper respiratory tract infection, which I said it is most of the time viral, then just plain giving antipyretics and adequate hydration should settle the child. Bronchodilators, wheezing, if you think the child has got wheezing or has bronchospasm, then giving a trial of MDI for a period of 6 to 8 weeks. If there are no tests available, or if you have a child who is younger than 5 years, then you can give a trial of bronchodilators if the cough persists. Now, antibiotics, in which conditions would you want to give antibiotics? Generally, if they are not effective and should be avoided in children who present with acute cough, mostly by viral URTI. But if you have something like pertussis, or if you're suspecting some atypical organism, then macrolide antibiotics should be prescribed early. Specific cause of acute cough, like I said, asthma or allergic bronchitis, croup, community acquired pneumonia. These are again diagnosed and treated on the basis of evidence-based guidelines. There is an entity called as PBB, or protracted bacterial bronchitis, where children come with chronic cough in children, and it is defined as chronic wet cough. But here the bronchoalveolar lavage will be positive and showing organism like Streptococcus, Haemophilus, or Moraxilla catarrhalis. An antibiotic therapy is given according to the sensitivity pattern for a period of at least 14 days. So generally what we do is, how do you evaluate the child? So first and foremost is a detailed history, then a detailed examination of the child. If you have an underlying specific cause for the underlying etiology, or if you think there is no specific cause, If you think that there is a specific cause, then you treat according to the underlying etiology. In this case, if you think that, if it's a foreign body, if you think that the cough is not settled and the cough has gotten wet, then you can suspect foreign body, depending if, especially if a small child between 1 to 3 years of age. If you think it's a cough which is non-specific and you're not able to identify the underlying cause, then we have a battery of tests we can subject the child to. That could be chest x-rays, lung function test, or any labscopy as indicated. So how do you do when it's a wet cough? If it's a wet cough, we would give a trial of amoxicillin clavulanic acid for a period of 14 days. And if the child, after giving 2 weeks of amoxiclav, you follow up the child after 14 days of therapy and then see how the child is responding. Likewise, if you have a dry cough, a child with dry cough, you can give a trial of inhaled corticosteroids for a period of 6 to 8 weeks and follow up after therapy. So when is the time or the right time that you refer the child for a subspecialist advice? If you think it's a chronic wet cough and the child is not responding to antimicrobial therapy, if you have a specific cause or if there is a specific underlying disease like cystic fibrosis or PCD or any chronic underlying inflammation and infection, or if you're not certain why the cough is because you don't have a particular specific cause, or if you feel even after giving medication like prolonged 3 months medication, or if the child has got recurrent protracted bronchitis that is more than 2 times per year, or if there is a suspicion of foreign body inhalation, or if you're suspecting any congenital or developmental defect, or if you have a child with chronic cough, which could be associated with persistent hypoxia and failure to thrive. So mind you, these are the usual causes of prolonged cough, which you think you have worked up the child in the manner that I have just mentioned. And in spite of that, if the child is not responding, there has to be some specific underlying inflammation or underlying congenital infection where we would need to investigate the child in a more deeper manner. So what would be our take-home message? So pediatric cough can range from mild disease like viral to severe life-threatening conditions like foreign body. Not all cough require treatment and medications should be used judiciously. Finding the specific cause, especially if it's a chronic cough and wet cough, and treating it accordingly is important. Early referral to a pediatric pulmonologist is crucial. Thank you.